The next session will be on nasal mass and polyp. It will be moderated by Dr. Amitavo Roy Chaudhary, and the faculties are Dr. Dopayan Mukherjee sir, Dr. Yogesh Jhabulkar sir, Dr. Shaumik Das, Dr. Diptanshu Mukherjee, Dr. Moinak Dotto, and Dr. Arvind Kumar
आपके लिए
Verma.
अलग कुछ नहीं रखा because you are observer. But good morning. So I think after the bombarding discussion on head neck, I welcome you again to this rhinology session, and it's my privilege to welcome Dr. Yogesh Jhabulkar, who is our AY observer and also is going to be contributing faculty for this session. Dr. Doipan Mukherjee, who is our current AY president, national president. Dr. Doipan, I would request you to come and take the chair. We will just take Dr. Shaumik Das, who is a professor from North Bengal Medical College. Dr. Diptanshu Mukherjee from Medical College, Kolkata, associate professor. Dr. Arvind Kumar Verma from Bakura.
Kindly maintain silence.
And also Dr. Moinak Dotto. He is from, he is an associate professor
make
from
silence in the
AIMS
auditorium,
Kalyani.
otherwise it will be very difficult to hear. Please
So,
be silent.
Just in the line of what has happened since morning, we are going to, my role here is just a facilitator for you to utilize all these faculty for your preparation. I am going to give you a 2 or 1 minute case scenario, and our faculties will take you through the discussion. Before we start, I would request Dr. Doipan Mukherjee to introduce the thing, and then we'll go ahead with the case discussion.
Okay, good morning everyone. So, at the time of final examination, after the ER case, the most important case is rhinology case, because either in the long case or in the short case, most likely you will get one rhinology case. And you will see the case scenario from Dr. Amitavo Roy Chaudhary. This will be a unilateral nasal mass. So you can get one unilateral or bilateral nasal mass, but as in previous discussion, it is clearly said that at the time of examination, we should not jump into the diagnosis. So we should proceed like this: history, examination, then provisional diagnosis, followed by discussion regarding investigation and treatment. So at the initial stage, we should not jump into the diagnosis. But I can tell you few of the other things in your generation. Most likely in your different medical colleges, you may not see that Caldwell-Luck operation, but all other cold conventional operations. But at the time of examination, you don't know who will be your internal or external examiner. So apart from all the modern surgical procedures like functional endoscopic sinus surgery or extended endoscopic sinus surgery, microdebrider, navigation and so on, you should know the basic steps of all these basic operations, so that at the time of examination, when some of the examiners may ask regarding those surgeries, so that you can give answer to those questions. And the pros and cons of these older procedures and the pros and cons of the newer procedures should be understood properly, so that you can give answer to those questions. So with this, I will request Dr. Amitavo Roy Chaudhary to start the case presentation.
Dr. Jhabulkar, we'll just an introductory comment, then we'll quickly start.
Good morning everyone, and I thank Dr. Doipan, Dr. Snehasis and entire AY West Bengal to invite me here as a AY observer. And I congratulate AY West Bengal for such a well organized event. This PG orientation was already happening at many places, but with the AY we are trying, Dr. Doipan has taken the initiative of bringing it under one umbrella. And I salute to all the teachers who have come here to orient the postgraduate students. and that too today is Guru Purnima. So I salute all the teachers who are taking the time and effort to orient the postgraduate, because the postgraduate students are already, many of them are well read, but sometimes they don't understand what is expected of them. So in that this orientation program will help and prepare them for the examinations. Thank you.
Thank you. I would quickly give you this history in just 1 minute maybe. We have got this 52-year-old female housewife who presented with a right-sided nasal obstruction for 1.5 years along with a right-sided nasal discharge for the same duration. And during the history of present illness, I think it was of insidious onset. I am not going to go through everything of the case because my next faculty will deal with that. And then there was also history of associated symptoms like intermittent bleeding on blowing the nose, etc. And also watering from the right eye, which is from the same side on and off for the same duration. On examination, we could find a right nasal cavity was completely blocked with a polypoidal pale looking mass, but a little variegated and irregular surface presenting at the nostril, and therefore obviously no examination was possible. It did not bleed to touch, and probing was obviously again not possible because the mass was presenting almost at the exterior of the nose, and oropharynx and palate were no this thing. Proptosis was not there, eyeball movements and visual acuity were normal, both TMs were normal and no palpable lymph nodes. And this is the CT scan of the patient. We will discuss CT scan very thoroughly. I will just give you briefly to say that the patient did have a unilateral nasal mass with some amount of bone destruction and some amount of bony expansion also, but strictly on the right side which was affected. And the MRI here, I think this will be discussed in detail. I am just give you an overview. That same right sided nasal mass, the other side was normal, and you can see that there is a mass in the nasal cavity and the maxillary antrum, and there is some collection in the ethmoidal sinus as well. And the density of these are totally different, fluid and soft tissue. So I would invite Dr. Diptangshu to take through the examination, and then we can, I think Dr. Davolkar and everyone can comment as we go along.
So, hello. So it is very important specifically to take the history and properly do the examination, because the issue is that long case will be given long case, you have to write properly, because some of the examiners obviously will check. A very few little will go to the last management. Otherwise, mostly the numbering is done within the history, within some questioning, and how are you examining. Some examiner, external or internal, may tell you, please go for sinus tenderness. This is very basic, but at the time of examination, what you feel, we also feel in our same time. Same. Hoy ekdom amader শুকিয়ে যেত, কিন্তু you have to do. This is the very basic thing. আমি খুব বড় বড় বললাম, কিন্তু বেসিক সাইনাস এক্সামিনেশনে আমি করতে পারলাম না. This is not good. তাই জন্য first you all know what should be written in the history, but just I am recapitulating. Okay. First, name, age, occupation, religion, address, socioeconomic thing, and this is the main chief complaint. Do not try to write more than 2 or 3 chief complaints. Patient may tell anything, but chief complaint should be precise. Like patient is having right sided nasal obstruction for 1.5 years. What Sarah said in this case, as nasal discharge in the right nasal cavity, but patient is complaining of nasal discharge from the right side from 1.5 years. It was same duration. You can add what is the type of discharge, but if specifically said by the patient that there is a blood is coming from blood staining nasal discharge, you can add, or you can make a separate point like bleeding from the nose from last few 6 months, no few days. You have to specifically mention the duration, last 2 weeks. And this type of like facial pain, reduced sensation, smell sensation in patient's own word, like sleep disturbance, if you can write, but try to avoid these things. I am writing this because sometimes patient tells so much of complaint, but you try to precise like nasal obstruction, nasal discharge. These two are my main problem. Along with there may be nasal bleeding. Now coming to history of present illness, First you will
আমি
write.
একবার interrupt করব just to make it little interactive. For example, he said history of bleeding. So then sometimes the examiner will stop you there. Why did you ask about bleeding? What does bleeding tell you? That kind of a question will come. What will be the answer? Why do you ask for bleeding?
Yes, এটা কিন্তু what she is saying you have to keep in mind. Bleeding বললেই first of sight is a case of malignancy. ফট করে বলে দিবি না। Sir, bleeding most commonly as patient is aged 56 year female and she is having some sinonasal মানে mass in the right nasal cavity obscuring the view of the surrounding structure and patient is also complaining of bleeding. It may be a case of malignancy or it may be inverted papilloma or it may be infected polyp.
That is very important.
Enteroconal polyp, you have to keep in mind that it may bleed. Infection মানেই যে malignancy mass এটা কিন্তু post graduation এ নাও চলতে পারে। Now first হচ্ছে history of present illness, patient was apparently well 1.5 years ago. Then you have to explain these 2 points, what nasal obstruction and nasal discharge. Some positive point, some negative point. This is the basic gist of the history of present illness. Like the mass which was insidious in onset, patient suddenly দেখতে পাবে না, insidious in onset, it is progressive in nature, that লেখা আছে progression. Duration, it was from the last 1.5 year, it is progressing day by day and it was associated with nasal discharge. Which is the type of nasal discharge? Nasal discharge is mucoid, it may be mucopurulent, it may be blood stained. তাহলে history of present illness লিখতে হবে। Along with the patient having history of repeated attack of cold or cough, running nose, there is hawking sensation like post nasal drip, border mass, there is a mucociliary clearance is hampered, so there will be post nasal drip. তাহলে hawking sensation থাকবে। You can mention in the history of present illness. If there is any bleeding episode, you have to separately mention that 6 months ago there was a bleeding episode, 1 or 2 anything, যেটা পেশেন্ট বলবে নিজের ভাষায় লিখতে হবে। মানে তোকে ফার্স্ট থেকেই তোমাকে গাইড করতে হবে, ইউ আর গোয়িং টুয়ার্ডস দ্য ম্যালিগন্যান্সি অর ইউ আর গোয়িং টুয়ার্ডস দ্য বিনাইন। তাহলে ইট উইল বি ক্লিয়ার টু দ্য এক্সামিনার অলসো। Facial deformity, if there, you have to write that there is a broadening of the nose, সবসময় এই ক্ষেত্রে থাকবে, অথবা there is a swelling of the cheek. These are the important point, but you have to mention in the history of present illness or if there is any proptosis or any eye movement বলছি। Past history specifically না আমাদের সময় no history of jaundice এসব লেখার থেকে ইম্পর্টেন্ট হচ্ছে in case of sinonasal mass, in case of ear cases, past history of any hospitalization, surgery, past history of any road traffic accident, কোনো সময় পড়ে গেছিল, there may be already fracture ছিল, but when we are doing CT scan we are seeing that it is a expansile mass, it is going in between the fracture, তো misdiagnosis হয়। তাই জন্য past history of any fracture or road traffic accident is very very important। আর history of tuberculosis past surgery লিখতে পারিস। Personal history very very important, smoking, alcohol, specifically এখানে occupational exposure, that is patient is a carpenter, lead হয়ে গেল।
Why?
কি type of carcinoma is more common, if it is a nickel, leather, এগুলো তো তোমাদের theoretical knowledge, but if you have to mention যদি থাকে, if patient gives typical history, catch it.
একবার interrupt করব। Again I am interrupting. Whatever you are going to frame and tell to the examiner, you should be having a formula of where you are going, which direction you are going, and you should be able to answer everything. Do not bring your theory knowledge, as Doipan said or Dr. Davolkar said, do not bring your theory knowledge in this. You should have the theory knowledge in background. So you should say simple things, and every point the examiner can ask you, why this, what does it lead to, why are you asking this? So you should be able to complacently answer this. That is, if you do not have knowledge, do not just skip some things, doesn't matter.
Yes, সব মিলিয়ে যাওয়া কিছুই করে
that is the
everything
trick.
is there, I am writing everything. You will মানে তোকে প্রথম থেকেই করতে হবে, I will write the positive point that after my history মানে examination and history, when I will tell the provisional diagnosis, every question and answer will be in the history and examination. সেগুলো তুলে তুলে আনসার দিয়ে দিলে এক্সামিনারও খুশি হয়। Now drug history, if patient is aspirin sensitive, Typical family history when needed, sinonasal mass তো জেনেটিক হয় না, বাট ইন কেস অফ বাচ্চা সিস্টিক ফাইব্রোসিস বা স্পেসিফিক্যালি ওর হিস্ট্রিতে কোনো আছে, অকুপেশনাল এক্সপোজার আছে, ফাদারের যদি কিছু পজিটিভ পয়েন্ট থাকে বা জেনেটিক থাকে, তাহলে ইউ ক্যান মেনশন. Now, general examination, same for everything. Patient is alert, having orientation of time, place, person. Now the vitals, pallor, cyanosis, clubbing, pallor লেখাই ভালো অ্যানিমিয়ার থেকে, pallor, cyanosis, clubbing, jaundice, pulse, BP, respiration, temperature, neck glands and neck veins is very very important in our cases, head neck surgery te. যদি neck glands থাকে, you have to mention here. Or you can separately make a point of neck glands বড় করে হেডিং দিয়ে. Skin condition of the face and neck সেটা মেনশন করতে পারো. Inspection I will come again. And there is look for any systemic signs যদি থাকে. Now local examination is very
Before
very
we go
important.
to local, anyone has got any other comment to add? Just quickly, if you want to add. No, if nothing, then we proceed.
Drug history separately mention করতে পারো. Personal history in case of female menstrual history mention করতে পারো. Now inspection, আমরা from the first inspection, palpation, specific test. আমাদের নাকের ক্ষেত্রে কি inspection, palpation, anterior rhinoscopy, posterior rhinoscopy and nasal airway testing. এইগুলো হচ্ছে মেন পয়েন্ট. তো ইন্সপেকশনে কি, অবভিয়াসলি পেশেন্টের রাইট সাইডের স্যার যে বললেন, পেশেন্ট ইজ হ্যাভিং এ ভেরি লার্জ mass in the nasal cavity, it may be in the sinuses, very mass, so it is blocking whole of the vestibule. So if there is any deformity, if you have to mention, otherwise when the examiner will say তুমি তো deformity তাই বলনি, there is a change in skin color, skin is at a fixed, তুমি তো বলোইনি, inspection you have to say that sir there is a change in skin color, it may be red, it may be pudgy orange, it may be if there is a infiltration, খুব কমন একটা কেস পেয়ে আছে এক্সামিনেশনে আগে, অলরেডি anterior wall ইনভেট করে গেছে, ইরোশন হয়ে গেছে, সো স্কিন ফিক্সিটি হয়ে গেছে, ট্রিটমেন্ট তো পরে আসবে, বাট ইন্সপেকশন ইউ হ্যাভ টু সে ইউ হ্যাভ টু রাইট there is a fixity in the skin, maybe due to fixity there is a change in the skin color and pudgy orange type. Any change in the color of skin, if there is any sinus tract fistula, if you have to mention. Now on palpation কি করি আমরা, generally we go for the sinus tenderness, but in case of sinonasal mass we should, if it is large and if it is deformity, we should palpate the structure. Why palpate? There may be, we can feel the extension. If it is very large, it is crossing up to the zygoma, infratemporal fossa, we may feel, যদি থাকে করবে. Tenderness over the sinus tenderness basic, sinus tenderness বলতে না পারলে পাসই করা যাবে না, তুমি যত কিছুই জানো. Maxillary sinus over the canine fossa with one hand. আমাদের সময় ডক্টর এসকে দের বইতে যা লেখা ছিল তোরা পড়িস না, সেটাই যা লেখা আছে সেটাই আমরা বলি, with one hand. Second, frontal sinus, you have to use the one hand. Only in case of ethmoid sinus you have to use the both hand. তুমি যদি এরকম করে করো, may not be, যদি ওল্ড এক্সামিনার হয়, আমি জানি না, নতুন এক্সামিনার অ্যাকসেপ্ট করতে
This is
পারে.
extremely important.
Now মোবিলিটি অফ দ্য নেজাল মাস, যদি মনে করো কোনো পলিপয়েডাল বা কিছু মোবিলিটি বাইরে থেকে থাকে তবেই করতে পারো. ইফ এনি বোনি এক্সপ্যানশন অর ডিস্ট্রাকশন ইউ ক্যান ফিল দ্য ক্রেপিটাস, যদি ইনফ্রা অরবিটাল রিম অলরেডি ইরোডেড ইউ উইল ফিল দ্য ক্রেপিটাস. ক্রেপিটাস জানিস তো? নাও অ্যান্টিরিয়র রাইনোস্কোপি,
Take the mic.
সেন্সেশন.
Yeah, we should look for the sensation over the cheek. Sometimes if the nerve is involved, infraorbital nerve is involved, there will be anesthesia over the, or paresthesia over the cheek skin. And one thing more, we have to look for the denture actually,
ওটা পরে আছে ওরাল ক্যাভিটিতে. তো অ্যান্টিরিয়র রাইনোস্কোপি, অ্যান্টিরিয়র রাইনোস্কোপি বলা মানে ইউ হ্যাভ ডেসক্রাইব দ্য মাস, এক্সামিনার বুঝে গেল এটা বিনাইন কি ম্যালিগন্যান্ট মোটামুটি. So what is it is sir, what has sir said? It is a large mass which is filling up of the nasal cavity. Sir has already mentioned it is variegated. ঠিক আছে, you should mention the color. If it is pale, pale কিসে হয়? অ্যালার্জি নয়, মাস তো পলিপ, এসি পলিপ তো রেড হবে না, এসি পলিপ পেল হবে, স্মুথ হবে, তাই না? যদি রেড হয়, ফ্লেশি হয়, তাহলে আমি বোঝাতে চাইছি সো ইট ইজ বিনাইন নয়, ইট ইজ গোয়িং আইদার ইনভার্টেড প্যাপিলোমা অর ইট ইজ এ ম্যালিগনেন্সি. সো বলতে হবে সারফেস, ইট ইজ স্মুথ, ইট মে বি স্মুথ, লবুলেটেড or it may be friable. Attachment, for attachment we have to do probe test, otherwise বোঝা যাবে না. কিন্তু so large mass we cannot do the probe test, but if can possible, সবার তো এত বড় মাস নাও আসতে পারে, you should do the probe test and you should do in front of the examiner obviously. Now bleeding on touch or not, in the probe test what we see, it is sensitive or insensitive, does it bleed on touch or it is arising from the lateral wall of the nose. তখন examiner
Then the question will
then
come.
the question will come.
What does mean sensitive means? What does bleeding means?
মানে if it is hypertrophied inferior turbinate, it will be sensitive. If it is mass, then all masses are insensitive. It depends on the which nasal mass you are having. Mostly insensitive, but it will bleed on touch. And if there is you have to mention if there is associated discharge, because if it is a large mass, there will be purulent discharge in the right nasal cavity. As well as you have to make a point of the septum. Septum is deviated to the left side, and you have to mention the opposite side also. There is a mucopurulent discharge in the left nasal cavity, but there is no abnormality detected. Only septum is deviated to the left side due to the mass. If there is any erosion, you have to mention that also. Now, posterior rhinoscopy, we generally do not do posterior rhinoscopy, but in case of a polyp or benign, or if it is very large, if it can be seen through the oropharynx, you can mention that posterior rhinoscopy is tried, there is a mass, but we properly could not localize where the mass is because of the patient incorporation or anything.
And I think all of you should be conversant with the procedure of posterior
Yes.
rhinoscopy, how it is done, in case it is asked. Because sometimes it may be asked. You may not do it every day.
Ekdom. Just I want to ask one basic question. Posterior rhinoscopy is done by anyone? Posterior rhinoscopy mirror বলে কোনো কথাই হয় না। Posterior nasal space mirror, এটার জন্য জিজ্ঞেস করছিলাম। These are very basic thing, undergraduate thing, but we will say posterior rhinoscopy mirror. Now, especially important in case of suspected call. The cotton wool test and spatula test. Cotton wool test, you know, you have to write. There is a grossly reduced airway in cotton wool test in the right nasal cavity. Grossly reduced, depending on the size of the mass. There is a mild restriction. There is a gross restriction. There is a not at all any mist formation in the cold spatula test. If there is a deviated nasal septum also, then in opposite side, you have to write there is a mild restriction, most likely due to the deviation of the nasal septum. This is very important in case of a sinonasal mass. Examination of eye, you have to write all the points. If there is nothing, but you have to write all the points. Like inspection, if there is any periorbital soiling, because most commonly it can, the roof of the maxillary sinus is formed by the floor of the orbit, so it can easily reach there. So if there is a periorbital soiling, if there is a proptosis, how to examine proptosis? Examiner will ask if your patient is having proptosis. Janis to? Stand. Arvind, will you add anything? Proptosis?
How do you examine proptosis?
Gauri, you can tell.
And I would like to see whether the sclera is visible beyond the supraorbital ridge.
Man, it is the easiest way to see the proptosis. Okay, chalega. Now ptosis and epiphora is there or not? Epiphora. In this patient there was epiphora. What is the cause of epiphora in this patient? Because of the huge mass, it is blocking. Now the palpation, orbital tenderness and crepitus, what I have told earlier in palpation. And visual acuity, if you have to mention 6/6 or 6/24, you have to mention. Ocular movement test to be done, and if there may be restriction of if there is an involvement of the ocular muscle, and pupillary reflex test, you will just write. No, Snellen's chart, it is a chocometry type. Obviously, you will not having Snellen's chart. But if patient can read 6 feet, and you will mention most probably that the no ENT surgeon will ask, how you measure the visual acuity, because it is not our domain. But you have to mention the point. It is by 6/6. And next, the cranial nerve examination in case of sinonasal mass. These three is very, very important. What Dr. Arvind said. V1, that is the ophthalmic branch of the trigeminal nerve. We have to test for the corneal sensation. And the 2 is the optic, and 3, 4, 6 is the oculomotor. These are the ocular movement, these are associated. So we have already tested, but we will mention in our history. These tests are normal. No gross clinical abnormality. These are a specific point. No gross clinical abnormality detected. Nothing abnormal is very bad thing. My sir, Dr. Shumit Basu told me, you have to write properly, that will be medico-legally correct. No gross clinical abnormality detected at the time of the examination. Now, examination of the year, I have not written all the points because it will be dealt with the COM time. So, examination, we are same inspection, palpation, otoscopy, tuning fork test, you have to write all. Just do not write like examination of year is normal. You have to write the point, you will get 40 minutes and you will know all the cases. Examination of the oral cavity. This is very important in case of sinonasal mass, specifically the oral hygiene. Condition of the teeth, is there is scaling, if there is any caries teeth, because if it is a mass, if we go for the post radiotherapy, then we have to remove all the caries. If there is a condition of the teeth and gum, palatal bulge is there. Palatal bulge, you have to mention that there is no palatal bulge. And the obliteration of the gingivobuccal sulcus, it is very common, no sir? Obliteration, if it is a large mass, so if it is causing erosion or expansion, there will be obliteration of the right sided gingivobuccal sulcus, and if there is a losing of teeth or not. Now the examination of oropharynx, only point that is anterior pillar, tonsil, posterior pillar, these are the normal, no clinical abnormality detected, and examination of the larynx like inspection, crepitus, there is no abnormality detected. These are the systemic examination, you have to write the point and you have to write the summary. So a 56-year-old female presented with nasal obstruction from the last 1.5 year along with nasal discharge from the same duration with blood staining nasal discharge from last 6 months. On examination, there is a right sided red fleshy mass obscuring the view of the right nasal cavity coming to the vestibule. On sinus tenderness, no tenderness was elicited, and on ocular movement there is no gross clinical abnormality detected. So my case is, it is a case of provisional diagnosis, you have to tell. So I will tell it is a case of right sided sinonasal mass. Most probably it is malignant. If I say this point, I cannot say or I can say. If I say it most probably it is malignant, then first question will be, why are you saying this is malignant? So we have to tell 56 years, second, blood staining nasal discharge, very short duration, within 1.5 years, it is occupying full of the nasal cavity with the deviation of the septum towards opposite side. If there is a loosening of teeth, very good, then it is going with your points. Then teacher will ask about the next question, what is the differential diagnosis, sir will take up. Okay. Thank you.
So I think it is extremely important what he has said. I want to again reiterate that whatever points you are saying to the examiner or writing, you should be able to have a proper answer the moment they ask. And from this provisional diagnosis, may I invite Dr. Shomik Das to take and discuss where anyone, all of us can contribute also.
So, as you can see from the screen, these are the common differential diagnosis of your case. So, as is given the history, I think it may be a case of inverted papilloma, most common, and then you can think of other cases. Of course, JNA at this age and a female patient, you can rule out. Antroconal polyp also is not usually common at this age. Nasal polyp, allergic fungal rhinosinusitis may happen, but as the history and examination has gone, probably is not the correct thing. Malignant tumors, yes, if there is loosening of teeth, if there is blood stain discharge, if there is short history, you can think of that. If it leads to touch. Fungal granuloma, this is quite common actually, more common than we usually think, and those who have been through the COVID phase have seen that everyone has faced this mucormycosis in their departments, and that's a grave situation and you have to tackle very, very urgently.
Can anyone tell me, if the examiner asks why this is not a fungal granuloma, what are the points against in this particular case? This is how the oral will go and long case crossing. Yes, anyone? What about history? 1.5 years.
Yeah.
Not mentioned.
Sir, on clinic,
Not mentioned to be immunocompromised.
compromise. And secondly, we usually in fungal grammar usually see black eschar sign, that is black or black turbinate sign and necrosis of the skin due to
Crusting
end
inside the nasal
arteritis.
cavity.
This is actually not present.
So
So
any item you pronounce, examiner will either ask you why not that. You should be able to tell that.
Yeah.
That this is how I am thinking. For example, again nasal polyp, allergic fungal. Why this is not allergic fungal sinusitis? Because allergic fungal sinusitis do present with unilateral disease sometimes.
Yes.
Anyone? Why it is not allergic fungal? This is how the discussion goes on.
Yes. Ball, pure ball.
Take. You can shout here. All of you are so young.
It's better to be wrong here than to be at the examination, isn't it?
Huh? Please stand up so that I know who is talking. Yeah.
So, in the history it was mentioned it bleeds on touch.
Yeah. This, okay. Anything else?
Anything else?
Mass. It will be pale. It will not be variegated. It will be smooth mass. You should ideally be able to probe it if it's a
Around it. Yes.
go around it. Then also there will be allergic mucin which has got a
type of discharge.
characteristic and the patient will explain
type of
it's like a sticky secretion and typically described in the textbook peanut butter like secretion. So those points will go against and the other things.
So, as we go on, in differential diagnosis, as your case is,
Enough.
the commonest thing you must say first, so that the examiner takes the cue and goes in that direction. Okay. So you must not, as is given here, as nasal polyp or allergic fungal rhinoceros as the first differential diagnosis. The case has been presented, most common is inverted papilloma, isn't it? Goes in favor of inverted. So start with that, and so that the examiner goes in that direction. Okay. Most probable diagnosis, because in provisional diagnosis you have to give one single. Most probably is the case of inverted papilloma, or if in malignancy, probably malignancy.
I will echo with him. There are some techniques to do well in the practical exam as well. As he said, you can most of the time you can direct the examiner to your direction, whatever direction, and in that direction the discussion will go. If you are intelligently coin your words.
Okay. So I think.
Next, tomorrow beta. I would now invite Dr. Moinak Dotto from AIMS Kalyani to take up the evaluation. Choto scan hi korte hobe because eta kete jacche. You can just go up and down. So he will take you through the CT scan.
Radiology portion is very, very important because it will also come in the time of the radiology. Same question in different time. The long case, the examiner will not ask, but when you will be given CT scan, then the radiology portion is important. And suppose it is a sinonasal, then the question will be again same thing. Ekhi jinish barbar. Now Moinak will tell.
Okay, with the case actually what sir discussed, this is a CT scan which what we can see. Now, anyone can you just say what is the finding in the CT scan? Because we have seen the history of the case, we have come to a provisional diagnosis, but now we need to see about the scan. The next thing is to do a biopsy actually, but before the biopsy generally we do an imaging. And imaging starts with a CT scan, plus minus MRI. So can anyone tell?
Can anyone describe the CT scan? Gauri, will you try to? Then come.
With a line and this correct.
Anyone? Mic ta diye do.
Describe the CT scan.
This is a non-contrast computed tomography scan in the coronal section, showing the nasal bone and a portion of the brain parenchyma, and I can see that there is a heterogeneous mass occupying the right nasal cavity and extending into the maxillary sinus and pushing the nasal septum medially. pushing the nasal septum to the opposite side. To the opposite side. It is also extending into the anterior ethmoids and has involved the,
Posterior ethmoid also.
right-sided ethmoids and also the sphenoid sinus.
Anything more? Any?
Sir, this is in a coronal section, sir. Soft tissue window.
How do you know? How do you
Sir,
see
the
that?
bony, if this was a bony window, then there would have been better demarcation of the, then I would have
And
seen
how
better.
can you read the scan and know whether it's soft tissue or bone?
Sir,
Something is written in the scan. Somewhere here. This is a bit blurred, you can't see. But there is something.
Sir, sir,
Anyone?
sir, Hounsfield units.
Hounsfield. So there will be W. W is, I think in W they write the, it can be, tumi bole dao? Hounsfield ta ekbar cover kor.
Hounsfield unit basically at a CT scan attenuation unit, okay, where we take the water as a zero, as a landmark, basically as a baseline. Okay, and based on that we develop the Hounsfield unit depending upon the texture of the content of the tissue, bone, soft tissue, fat, whatever it is. Okay, so ekhane actually for a very grossly to understand, if you see the CT scan, you can see a thickening of the bones hoye ache na. These bones, this gives an idea it's a soft tissue window basically. Okay, if you had been a very thin bone windows, you can understand it's a bone cut. But this is basically a soft tissue window. And there are two things you did not mention or mentioned wrongly. One is it is a contrast enhanced. Okay, how to understand it's a contrast? See the ventricles. See, these are the contrast in the brain. Okay, so it's not possible to see that plus C. It's written there, but সব সময় দেখা যায় না, ঠিক আছে? But সেজন্য কি করতে হবে এখানে? You have to see to the ventricles. You can see some contrast is there. So it's a contrast enhanced. And also it did not mention about the window at that time. যখন তুই বলেছিলি।
Okay, we can proceed. I will just say again that the way she started to speak about the scan was good. Yes. This is how you should approach. You should never say that I can see a mass in the right maxillary.
Don't jump into the...
What is the scan? Which region is scanned? What is the nature of the scan? Contrast, non-contrast? Then you need, if a Hounsfield if possible, soft tissue bone window. Then you can start describing the normal structures one by one. So that is a good way to do it. So we'll just go to the next. Dr. Moinak will take you through the nuances of the CT scan, question wise. Huh?
কখন আমাদের সিটি স্ক্যান করতে হবে, ওকে, কখন আমাদের পরীক্ষায় দেবে সিটি স্ক্যান? অ্যাকচুয়ালি ইট উইল মে কাম ইন 3 ways. Number 1, in the long case or short case viva, সেখানে জিজ্ঞেস করবে টেবিলে, there will be a separate table for the imaging থাকবে, আর একটা হচ্ছে in case of grand viva, এই তিনটা জায়গাতে স্ক্যান will come. Now first of all let's go, we'll pick up 3 questions. We have taken up 3 questions. Question 1 is that what purpose does the imaging serve in the evaluation of this anonasal mass? Okay, this you all know, but first of all let's deal with one by one. Extent of the lesion or involvement of the internal structure. That is a very important point. Now you know by this time the patient details of the patient, but we need to know how the mass is involving the internal structures and what are the proximity of the mass is going to. So what are the things you have to note? First of all, very important, the nasal cavity. The condition of the septum is very important. Okay, you have to see the deviation of the septum to the opposite side. Some vital structures like the skull-based pneumatization, the migration of the anterior and the posterior ethmoidal cells, these have to identify. Then also the level of the anteroethmoidal artery, the olfactory fossa, all these things you have to see at a glance, and the orbit, whether the mass is involving the orbit or not. And these things, and the involvement of the paranasal sinuses, maxillary sinus, anterior and the posterior ethmoid, this you have to see. Next also the changes in the bony architecture, whether it is erosion or remodeling. Now these two are not the same thing. Erosion and remodeling. Erosion means basically a visible breakage of the continuity of the bone. It does not mean that the histologic breakage, but it's a imaging breakage. You can see in the imaging. And remodeling means basically the continuity is maintained, but it is either thickened or thinned out. We can have these things in the next slides.
Specifically in a single cut,
you cannot mention that it is a erosion or it is a thinning. So you have to take 2 or 3 cuts.
Multiple cuts. That's why these multiple cuts are there. You can see here in this left maxillary sinus mass, it is basically a pressure situation is there. The mass is occupying the left maxillary sinus and there is pressure expulsion, resulting in thinning of the walls of the maxillary sinus. However, the same, you can see another patient, here there is some fungal rhinosinusitis. You can know this is fungal rhinosinusitis, but there is some reactive osteitis, resulting in thickening of the this maxillary sinus wall, both in the soft tissue and as well as the bone windows. Now here you can see, as we have seen in our present case, that there is a erosion, definite erosion of the floor of the maxillary sinus. But in this particular cut, you can see that there is maybe a malignant mass in the left maxillary sinus, but there is a combination of both remodeling as well as there is erosion in the posterolateral wall. So these are the next hoche decision making. Now decision making is another indication for which we do a CT scan. For example, suppose there is a chronic rhinosinusitis with nasal polyposis. I am subjecting this patient to appropriate or maximal medical therapy. Now there may be one of the 3 situations after the therapy. You are done with a follow-up cut. You can see that still after the MMT there is this is a condition of the sinuses. So in this case we have to go for surgery. This is one decision. Situation 2 may be like this, that there is a mucosal thickening in the maxillary sinus with blockage in the osteometal complex. Here you can, I will go for a middle metal anterostomy on the left side. But in the third cut, in the third situation, you can see there is minimal maxillary thickening, maxillary sinus thickening. Here we can wait and watch. So this here, the CT scan can give us an idea of how to approach to a case following a intervention. Secondly, also the second question is, when are we going to advise a CT scan, MRI or both? Now generally the CT scan is the first line of investigation or imaging investigation we tend to advise, because it is easily available, is cheaper, and actually it is easier to read than the MRI. However, we can add MRI as an add-on. Next slide. When we suspect a differential consistency, suppose there is a sinonasal mass in the maxillary sinus, an enteroconal polyp or a chronic rhinosinusitis with nasal polyposis, but there it may so happen that the polyp itself is occupying a particular area of the nose and PNS, but the remaining part may be simply mucosal thickening or any secretion or pent-up secretion. That will also lead us to a management decision. Suppose you can see here you can see that there is a mucosal thickening of the sphenoid sinus and also in the posterior ethmoid. But actually, if you do in the CT scan, if you do an MRI here, you can see that actually there is a collection in the posterior ethmoid, but the sphenoid sinus has some definite mass. It's basically a fungal debris or fungal lesion in occupying the sphenoid sinus. So you can differentiate between the two. That's why the MRI is needed as an add-on. Next is a differential consistency. Again, you can see here there is a mass lesion occupying the left maxillary sinus, encroaching to the nasal cavity because the medial wall is broken. But if we compare with the opposite side, you can see there is an inferior turbinate. So we are not sure whether the inferior turbinate is there or not, how much is the medial extent of the mass. So if you do an MRI here, you can see, yes, it is basically the mass lesion which is coming into the nasal cavity, breaching the medial wall, and it is not the inferior turbinate. You can get an idea of the exact extent of the mass involving the sinus or the nasal cavity. Next is very important is the intracranial extension. Suppose there is a skull-based lesion, it may be a malignancy or whatever it is, or even a mucocele. Here the CT scan, you can see the sphenoid sinus greater wings are basically the masses growing along the sphenoid sinus greater wings. But the corresponding MRI you can see here that there is a bone, there is no suspected bony breach. It is basically grazing along. But here another situation, there is a mass in the posterior ethmoid and adjacent to the pituitary. But here you can see that there is a definite breach in the skull base, but it is extradural, intracranial but extradural. So these ideas you can have only with an MRI, not with a CT scan. Next is the intraorbital extension. It's very important. See here there is a mass lesion in the, if you see the sequential cards from superior to inferior, you can see there is a mass lesion involving the maxillary sinus and it is actually coming to the orbit. But you cannot differentiate what is the extent, how extent the orbit is actually involved. What is the size of the mass and how the orbit is involved. The corresponding MRI you can see, you can clearly delineate between the mass lesion here and the orbit here. How much the orbit is involved, you can clearly see from the corresponding MRI. So intraorbital extension is very important. Next is the cribriform plate dehiscence. You all know a patient coming to an active CSF leak, you do a CT cysternography. This is the image of a CT cysternography. But you are not sure what is the content of this herniation. It may contain only CSF, it may contain the brain matter. So to be sure, you can do an MRI, MR cysternography. Here you can see that there is a huge amount of CSF, little bit of herniation of the brain. And when we do MRI as a sole imaging, so nowadays with improved quality on the readability of the MR scans, we can directly advise MR as a first line investigation because it will expose the patient, not expose the patient to any radiation hazard. And so for example, the cribriform plate dehiscence in case of a meningoencephalocele. So next slide. The same patient, suppose the earlier patient, if you could just opted out of the CT cysterno and directly advised an MR cysterno, then we could have the same information is available here. The bone, the breach in the bone as well as the content in the herniated sac. Similarly, in the second, in this cut also you can see that there is a gross herniation of the brain matter into the nasal cavity which is only evident in an MRI. It cannot get an idea in the CT scan. Similarly with the vascular lesions, for example JNA. The involvement of the JNA is very important, including intracranial extension if it is suspected. So we can directly go for a MR with contrast. Even with a T2 enhanced MR, we can have an idea regarding the vascularity or the consistency of the JNA. Here you can see the extent of the JNA here, and no CT scan was done in this patient. Similarly, a vascular tumor like a maxillary sinus hemangioma, the MRI becomes a first line of investigation rather than a CT scan. Very importantly is the mucopyocele, the fronto-orbito-ethmoid mucopyocele. Here see, this is a MRI done. All these will reveal the mucopyocele and they provide the same, rather more information than we do a simple CT scan of the mucopyocele. We can have an idea of the extent as well as the content of the mucopyocele, whether it is a purely mucus or a mixture of pus or mucus. Now very importantly is how to read a
this has been covered no? Already. Partially. Just partially covered.
What are the points you need to remember? Points ki mone rakhte hobe, first of all the cut. The scout film we have to have a look. We just miss the scout film. It's in the top left corner.
Why don't we ask a question to them? We have discussed plenty. This question let them answer. When a CT scan is asked to be read, what are the points you describe? Anyone?
Sir, the modality of the CT scan, whether it is a contrast enhanced or a non-contrast, the anatomical structures that are being visualized, like is it a nose bend PNS or with NCCT brain, or and then we will come to the cuts, the sequence of the cuts, and then we will come to the window that is being visualized currently, and once we have explained which window is it, and we have already said the cuts, we will see from which how the cuts are progressing, whether it is from anterior to posterior as in a coronal cut, or whether it is from superior to inferior in an axial cut. So after the progression, we will now come to
and parasagittal?
And parasagittals are lateral to medial.
Generally from right to left.
So next we will now come to the normal anatomical structures and describe the normal boundaries and the normal structures that are as visualized on the CT scan. Then we will come to the pathology, that is the main focus, which and describe the pathology in detail, focusing especially on the extent, the involvement of any other structures surrounding that lesion. And also we will comment on the type, if possible we can comment on the type or the composition of the pathology, whether is it a differentially enhancing lesion, heterogeneous enhancement or homogeneous, whether is it vascular. If we have a contrast enhanced, we can comment on the vascularity, or in an MRI we can also, again if it is having an MR angiography or MR venography, then we can comment on that. And then finally, to summarize, we will summarize all our points, and give a provisional
Excellent.
diagnosis.
I think she
All
has
the points are
answered
covered.
all the. We take it you as a representative, and we take that everyone has understood the same. We can give you honors for that answer. I think very good. Very
এইটুকু পুরোটা
comprehensive.
বলতে পারলে ঠিকঠাক।
FRS.
Before we go to
Just,
the
yeah, very
biopsy,
important
actually, just
point
there are some
which is given.
few important clinical, important sinonasal situation, diseases, important cuts are there. See, identify করো, কে বলবে এটা বলার কিছু নেই, you all know. This is a axial cut, bone and soft tissue window of the nose and paranasal sinuses showing what? A heterogeneous lesion.
So this is a contrast enhanced CT computer tomography of nose and paranasal sinuses showing the axial cut and also the orbit is can be seen. Here we can see a heterogeneous mass involving the left nasal cavity and going to the maxillary sinus as well on the left side, and deviation of the septum towards the opposite side. There is no orbital involved, and there is heterogeneous double density sign. Yes, sir.
Reason?
So because of the manganese and calcium ion deposition of the, yes, sir. Allergic fungal rhinosinusitis.
Fine. I think we'll proceed to the next section. This is the last for CT scan. Somebody else from the back? Anyone? Just salient features and what is the sign?
Sir, this is a non-contrast CT scan of nose and PNS in axial section where we can see in bone window where we can see a homogeneous mass occupying the left-sided ethmoid and sphenoid sinus, and it is maxillary, yeah. Oh, acha. Yes. Then
I will.
This is a mass lesion we can see occupying the left pterygopalatine fossa and infratemporal fossa, and also in the posterior half of the nasal cavity encroaching towards the nasopharynx, and there is the anterior bowing of the posterior wall of the left maxillary sinus. This
I will ask one question to them, that suppose this was a CT scan of a patient, a young male who presented with a nasal obstruction and recurrent epistaxis. This is the finding in a non-contrast scan as we have seen. Will you be happy to take up the patient for surgery or will you do some other scan? These are the questions which are asked in the exam.
Is for a contrast enhanced MRI and an MR angiography with it. MR angiography with it.
MR?
An MR angiography and in the same sitting a contrast.
Okay, so more or less CT is covered. Now the patient, we come back to the patient in question, and obviously biopsy. What is the next step?
Yeah.
How will you do it?
So
Dr.
from,
Das.
Radiology, you have got a decent idea about the mass present in the nasal cavity and around the surrounding sinuses. Now what you do? So the next logical step is to do a diagnostic nasal endoscopy, and most of the cases you have to take a biopsy and send it for histopathology. Okay. Along with that, the blood tests, and obviously some cases when you suspect malignancy, you have to do a chest X-ray. Okay. So how about imaging? About nasal endoscopy. This is the gold standard for nasal examination, as you all have been doing it in your PG days. So what do? You have a direct visualization of the nasal cavity, sometimes sinuses, and also choana. It helps to assess the origin and the extent of the mass. Of course, in all cases you cannot do that. Like in this case, you cannot do because the mass is filling up almost the nasal vestibule. So you cannot go beyond that. So in these cases, you have to go for biopsy. So do you do biopsy in all cases? In which cases you do not do? Like the last CT scan you saw, it's a case of mesopharyngeal angiofibrosis. So definitely you will not do a biopsy. Okay. So from all investigation you have got an idea and you have to set the patient up for full surgery. And this also has been discussed in mucormycosis. You take a biopsy, you don't get so much time. So you do a nasal endoscopy, you see the crust and the destruction, and take a nasal swab and do a KOH mount. And if it comes out non-septate hyphae, you just go for the debridement, seeing the extension by the CT scan and MRI. Of course, if you have the extension in the brain, it's difficult to do a debridement. Only debridement will not help the patient. But sometimes if the brain is escaped, then you can, if the orbit is involved, you go for orbital extension. Along with the lesion, you do a maxillectomy or a medial maxillectomy, and if the orbit is involved, the orbital extension. So do the same thing in malignancy cases. Yes, of course, you take a biopsy, but sometimes, as you know, in nasal cases, you will get some round cell tumors also, like a Ewing's carcinoma, like rhabdomyosarcoma in children. So in these cases, immunohistopathology is histochemistry is the most important test for diagnosis of the tumor. And with that immunohistochemistry, you can finally treat the patient, whether it will be surgery, it will be the combination of surgery, chemotherapy or radiotherapy, then you can diagnose that. Okay. So now is the other question, how will you proceed in CA maxillar cases where there is no mass in the nasal cavity? These are asked in the questions. So in this case, of course, you have to take a biopsy from the maxillary antrum by doing an arsenectomy and then a middle metal antrostomy. In here, as you said, the older examiners may ask whether you can do a cardiolog biopsy or not. How many have you done cardiolog in your life? I have seen cardiolog in your department. Have you seen? Very good. Very few, I think. So almost nowadays we are not doing cardiolog.
But will you do a cardiolog? Sorry to interrupt. In this particular patient with unilateral nasal mass.
That is the question that is
How
asked.
many of you will do a cardiolog biopsy and take biopsy from maxillary?
Because it's very easy. You just cut the bony and anterolateral wall of the maxilla and go inside and take a biopsy.
So nobody.
But will you do that?
Kyun na?
Why not? Cannot.
Yeah. Stand up and answer.
Yes, it will definitely upstage the tumor and it will come out
Absolutely.
to involve the skin and subcutaneous tissue. So it will definitely not Also another case where you should not take a biopsy, if you suspect some malignancy or some tumors coming out from the brain, like a meningoencephalocele. There if you take a biopsy, you may land up leaking CSF. Okay. So in these cases maybe you have to prepare, take a neurosurgeon along with you and do the surgery if it is possible in your center, or you send to some other higher centers where with the help of neurosurgeons they can do the thing. So suppose a mass, as in this case, it has almost come out of the anterior nares, how to take a biopsy? Do you take a biopsy from just superficially? Then it will not come as a representative. So you have to go deep and take multiple biopsies, preferably 3 bites, so that you get a correct diagnosis. Okay. So I think
one thing I will add, when we will tell after the differential diagnosis, first examiner can ask what is the investigation of choice. If say examiner will ask this, then it will be the answer that it is a contrast enhanced CT scan of the nose and paranasal sinus. And what is the confirmatory or gold standard investigation will be the nasal endoscopic guided biopsy with a representative sample from the core area of the tumor. Otherwise it will be negative.
Okay, I think
So as we have gone through the case scenario, we have decided that still the investigation, it's a unilateral nasal mass, and considering the CT scan and everything, it looks like either a benign or a malignant tumor, neoplasm. So now quickly we will run through few surgical steps and the question answer. in relation
Sir,
to the...
one thing I will add regarding the nasal biopsy, very practical question. How will you take the biopsy? It is very pertinent with the MS as well as DNB examination. You should learn the procedure. What it should be taken under local anesthesia or general anesthesia? Always preferably under general anesthesia. First we have to decongestant. তাই না decongestion করতে হবে, we have to do, and examiner may ask with what is the percentage concentration of the adrenaline, what you will give. You have to tell in the exam everything, that what is the procedure, then we will go for the biopsy.
So in general, all malignant disease, you have to do examination under anesthesia, everything in the upper airway. So this is not an exception. This is an exception because the mass is outside the nasal cavity, but otherwise you have to follow the same principle, because staging will also come from your endoscopic finding. That will be, so staging has to be correct. So had it been a benign mass like an allergic fungal sinusitis, we would just take you through the step, because this will be asked in the examination, and then we will take you through the steps for a maxillectomy, which are very common questions in such a situation. So first of all, can anyone tell me what are the steps of uncinectomy? As we know, this is the basic step for a functional endoscopic sinus surgery. Anyone? Just highlighting points. You do not have to describe. If not, I will have to tell. All of you would have done at least some uncinectomies. Yes, there is an answer.
So there are two techniques of uncinectomy. One is conventional technique and one is swing door technique. In conventional technique, we put the incision anteriorly. Like we have three parts of uncinate process: the vertical part, the middle part, and the horizontal part. So the incision is started on the anterior aspect. First, we use a ball probe to palpate the lateral margin or medial margin of the uncinate process. We see the ballotment. Then we engage the ball probe and evert it. After that, we use a sickle knife, which was done conventionally, but that had a risk of orbital fat prolapse, so it is not done more commonly these days. After that, we came across the wormholes technique, that is the swing door technique, where we use backbiting forceps. In this portion, what we do is we remove the middle portion of the uncinate process so as to find out the maxillary ostium, and after finding out the maxillary ostium, we enlarge the maxillary ostium.
Very nice. This kind of an organized answer is what the examiner wants when they ask you a question. So what she described was something like this. If we can go here. Yeah. So first of all, you do palpate the uncinate process and see the location of the uncinate where it is attached. Then you can either put a sickle knife here, which is the conventional technique as described, and remove the uncinate, or you can do that was right side, this is left side, along with a polyp. Again you palpate. First of all, your probe is now going into the infundibulum, so we are gauging the depth of the infundibulum so that you do not go enter the orbit, and then take your backbiting forceps, and again palpation is very important because you know that you are not very close to the orbit. There is enough space for the instrument to go and house there. So make a cut, as she said, between the horizontal and vertical part, which is also called a Parson's window, and then you primarily, if you are doing maxillary sinus disease, you remove the lower part. This is the horizontal part of the uncinate process. You can either use a debrider or any other forceps, and then you go upwards if you are going to do the ethmoidectomy and frontal sinus disease. So this is essentially just a middle uncinectomy and middle metal antrostomy done. Now what are the complications? I mean, I am just going question wise very briefly. This will be exactly asked in the examination. What are the complications of uncinectomy and middle metal antrostomy? Just to show that this is another middle metal antrostomy, as she mentioned that you can use a micro debrider, and this is the situation. You have anterior, posterior, inferior, superior. Can anyone tell me what are the complications if you go too much anterior here? Anterior, some other faces will be better, but you answer.
Sir, nasolacrimal duct injury can be there when we go anterior.
So if you go anteriorly, if you go superiorly?
So there can be orbital injury leading to orbital fat prolapse.
Any other volunteers for the posterior and inferior? No? Then you tell us.
Posteriorly, there can be injury to sphenopalatine artery. There can be
কেউ
bleeding.
আছে? বলো। Anyone?
Sir, if we go to posteriorly, we'll be going into the sphenopalatine space, the pedicopalatine space, and then we'll be injuring the sphenopalatine ganglion, which lies actually
Sphenopalatine ganglion and artery. Okay.
An artery.
And too much
If we go
inferior.
inferiorly, we'll be creating an oroentral fistula actually. I mean, we'll be
Oroentral fistula will be too drastic, but at
that
least
is,
you can injure the inferior turbinate totally.
Yeah.
So these are the primary, and if you go medially, laterally, what will happen? Superiorly and laterally.
If we go to superior laterally, we'll be kind of injuring the temporomandibular joint, which can be.
You are always going too much away from the.
अरे auto lateral no.
Auto दूरे के जाए?
Temporomandibular joint the far away. You are doing face na.
See, as she said, superiorly you are going
Lamina
to the orbit.
papyracea.
So, and superior and lateral also you are going to the orbit. So, lamina papyracea can also be injured. Now, what are the disposition? Can anyone tell me? This is right nasal cavity, which is natural, which is accessory ostium. Anyone? Yes, Mike?
Sir, when we are entering the nasal cavity with a 0-degree Hopkins, if we are able to see any ostia without performing any procedure, that is likely to be accessory ostium. And also it is just lined by mucosa and doesn't have any bony margin.
Okay. And what do you do when you have ostia like this, two ostia?
We unite them both into a single large cavity.
Jodi, if we do not do that, what will happen?
It will impair the natural mucociliary clearance.
This is just joining the two ostia here, making it one. Okay? Now, as I said, we'll spend more time on maxillectomy. This is just to make sure that you are able to fluently answer. What are the steps of anterior and posterior ethmoidectomy? Where is the best location to puncture the bulla? These are the questions which are asked. Yes? Antero? Inferior. It is inferior and
Inferomedial.
Medial. Inferior and medial. Like this. This is right nasal cavity. Somehow it's not playing. So this is the area where you puncture. This is what is the other technique? There is some called retrograde bulla resection. Anyone?
Sir, we can go for an intact bulla technique where we first try to identify the sphenoid ostium, and that is our posterior limit, and then everything in front of that basically becomes a garbage and we can remove it.
Okay, like this. So you go behind the bulla and remove the bulla, and this is the ground lamella, and then you puncture the ground lamella. Quickly, we will go. This is, what structure is this? Left nasal cavity, we are sucking. We are going towards the frontal recess. What is this structure? Anterior ethmoidal artery. What will you do if you pull it out accidentally, intraoperatively? Or what can go wrong? Yes? Mike?
It shrinks into the orbit. Orbit is a closed space and it leads to orbital hematoma formation. If there is a orbital hematoma compression, we will go for lateral canthotomy followed by cantholysis. If this is not removed, then we will done the inferal canthotomy. After, if it is still not resolved, we can approach it externally.
Okay. In the interest of time, we will accept that and go. What are the complications of ethmoidectomy? I think I have already shown it. Obviously, injury to the skull base, if you go superiorly, that can lead to CSF leak. If you go laterally, entire lamina papyracea is exposed after ethmoidectomy, and obviously injury to the anterior ethmoidal artery. These are the complications amongst many. And just we'll finish in 1 minute. What are the various approaches to the sphenoid sinus? Anyone else who can answer? Approaches, intranasal approaches, how to approach the sphenoid sinus?
medially, intermediate and lateral approach. Most commonly we do the intermediate or the medial approach.
So fine, I'll just show you those who are not familiar with this. This is, you are going behind the superior turbinate, identifying the natural ostium and opening. That is just like opening the natural ostium of the sphenoid sinus. That is the median approach or paraseptal approach. If you go from the ethmoid side, ethmoidectomy cavity here, sphenoid sinus will be here. If you puncture here directly, it will be the lateral approach, but if you go towards the superior meatus from here into the through the middle turbinate, then you can again identify the natural ostium and join the natural ostium with the ethmoidectomy cavity here. So this is actually a lateral approach which is just going posterior inferior to the ethmoidectomy cavity, and this one is actually too much of polyps here, difficult. We will just pull it through here to understand that from this side we are going towards the superior meatus area, where you can see some fungal collection is fungal debris is there, and then identify again the natural ostium and join the natural ostium from the natural ostium side into the sphenoid sinus. And last, I think I will just show you, not ask question, what structures may be injured. These are the questions which are asked in the exam. Obviously, you can injure the carotid, you can injure the optic, you can injure the hypophyseal fossa. Most commonly, these are the things, and obviously cause CSF leak in the sphenoid sinus. I would hand it over to Dr. Arvind now to take you through maxillectomy, which is very commonly asked in the examination.
So from the above discussion, it is clear that we are dealing with some neoplasm of the maxillary sinus. So anybody, what should be the management of this patient? Anybody?
Sir, the goal should be complete removal of the mass, and also to prevent any recurrence, preferably drilling out the site of origin, which is most likely the lateral wall of the maxillary sinus in this case, showing hyperosteosis. So this patient, for adequate exposure, if we are even going for an endoscopic approach, we will have to do a medial maxillectomy, or we can go for a midfacial degloving approach. So the mass removal with the source is the main goal.
So this patient is going to need some kind of maxillectomy. There are different types of maxillectomy. So I'll briefly go through that. By the way, before going to maxillectomy proper, the extent of surgery, what kind of surgery we'll do, will depend on the nature of the pathology and extent of disease. Extent we have already known by the imaging. So extent is better described by the staging system of the, neoplasm. We also follow TNM staging in the nose and paranasal sinuses, but there is one drawback. This staging is not applicable for the mesenchymal tumors and olfactory neuroblastoma. And second point which I would like to highlight, that any tumor which goes beyond the maxilla, except in the nasal cavity and palate, it is regarded as T3, that is advanced tumor. Other things you can go through the TNM staging. I am not going into the detail of that. Now what is maxillectomy? Maxillectomy is the removal of a part or whole of the maxilla, sometimes with the ethmoid or part of the orbit. What are the types of maxillectomy? What are the types of maxillectomy? Anybody? Anything.
Any answer is acceptable.
Sir, medial maxillectomy is where we remove only the medial wall. Other than that, it may be classified into partial and total maxillectomy. Partial is removing part of the.
Yeah, got it. So for the simplification, we can divide it into the partial maxillectomy, total maxillectomy, and extended maxillectomy. But there is a lot of confusion regarding the nomenclature, and there are a lot of paper in the literature like Liverpool classification, Spiro classification. You can go through that, but for examination point of view, you can go with that. The partial maxillectomy In this, we deal with the commonly performed procedures are medial maxillectomy and infrastructure maxillectomy. But suprastructure maxillectomy can be included in this category also. And total maxillectomy, where we are removing all the maxilla. Then comes the extended maxillectomy. In this, we can include radical maxillectomy with the vital excitation. And sometimes when we are doing craniofacial resection, we have to do maxillectomy. So these are the types of maxillectomy. Now indications, mostly tumors, but COVID had taught us very hard lessons regarding this particular entity. Mucormycosis is another indication for the maxillectomy. Now coming to the incision planning. Anybody has assisted in maxillectomy procedure or have done any maxillectomy? Anyone? ওই সব করেছে কিন্তু কি maxillectomy তুমি assist করছো? হ্যাঁ
On a lighter note, he will be banned now from answering.
So medial maxillectomy, sir.
Okay. What was the incision used in the medial maxillectomy?
Sir, lateral rhinotomy incision, that is the mood incision.
Okay. Are you aware of any other incision?
Sir, for the Weber-Ferguson incision with the modification.
Okay. Okay, great. So there are four approaches. One is the lateral anatomy approach. Okay. But this approach is gradually going, we are using less and less of this approach because of development in the endoscopic technique. Most of the lesions which were used to be removed by lateral anatomy approach are now easily removed by modified Denker procedure. Another is Weber-Ferguson incision and its extension. This is a very common incision and this is very useful incision. As you can see, this incision starts somewhere between the midpoint of dorsum and medial canthus. It goes caudally into the nasofacial groove, then again into the nasolabial groove, around the ala to reach the vestibule and then to columella. After columella, it has a vertical limb which bisect the upper lip. So this whole incision is Weber-Ferguson incision. And any given kind of maxillectomy can be performed with a Weber-Ferguson incision or with its extension. What are the extension of Weber-Ferguson incision? This yellow line.
Lynch incision.
What is this is when we used to give this incision? I mean extension.
For ethmoids, sir.
For ethmoids, very good. And what about this extension?
Subciliary.
Subciliary. When will you use this incision? Extension?
All beats.
When you are going to do total maxillectomy.
Total maxillectomy.
Okay. So this is about your Weber-Ferguson incision. Then another very important incision is mid-facial deglottal. This incision is important because it doesn't create any scar mark over the face. So we have to give one incision in gingivo-labial and gingivo-buccal surface. It starts from the first molar of one side and goes up to the first molar of other side. Then we have to give incision in the nasal cavity. One incision is transfixion incision at the caudal end of the septum. Then this incision is joined with the intercartilaginous, that rhinoplasty incision, the famous rhinoplasty incision. The transfixion incision is joined on the both sides with the intercartilaginous incision, and that incision is extended in the floor and lateral of the nose. So whole thing can be limited and you can get a good view of bilateral maxilla. And the important thing, we are not putting any incision in the over the face. So it provide a very good cosmetic result. I am not going into detail of modified Denker endoscopic procedure which are currently used for inverted papilloma more and more. So now coming to bony cuts of the maxillectomy. Before going into the detail of bony cuts, can anybody tell me about the processes which maxilla have? How many processes are there in the maxilla? Stand up, anybody?
So frontal process of maxilla, zygomatic process of the maxilla, and alveolar process of the alveolar.
Zygomatic, palatal, anything else? Alveolar process, Anything else? Very important.
Fronto.
Frontonasal. Frontonasal process. So there are 4 processes. So with this process, this maxilla has different attachment to the skull bone. Okay. One more attachment is there, that is the pterygoid process, attachment of pterygoid process. But this process is not directly attached to maxilla. It is attached to perpendicular plate of palatine bone, which is a part of hard palate. Okay, I mean that horizontal process is the part of hard palate, and the vertical process of palatine bone is attached to the pterygoid process. So now if we have to remove the maxilla in any maxillectomy, any given maxillectomy, we have to plan the cuts. One thing, before going for a bony cut, we have to do all the soft tissue work, because bony cuts bleeds a lot. So after doing all the Weber Ferguson incision and elevating the cheek flap, we have to plan our osteotomy in such a way to minimize the bleeding. Because just behind the maxilla there is internal carotid artery and its branches. So any injury to that particular thing will lead to a lot of hemorrhage. Okay. So first cut we'll put on the zygomatic process. Second cut we can go for this one. Nasal bone. Attachment of nasal bone is cut, and this cut is extended in the orbit just below the frontoethmoid suture line. Why below the frontoethmoid suture line? What is the reason we are extending the cut below the frontoethmoid suture line?
Sir, we may injure the cribriform plate. CSF, sir, we may injure the cribriform plate.
Yeah, that is the level of cribriform plate. So if we go above that region, we can enter the intracranial cavity and can lead to CSF leak. So we have to remain below the frontoethmoid suture line. Then this zygomatic cut is again extended through the infraorbital fissure, and both cuts are joined posteriorly. Another cut is in the palatal region. Palate is cut in the midline, or sometimes we try to avoid the midline. We take a cut from starting from the in between the canine and lateral incisor, and give an oblique cut, reach the midline, and then cut the palate. This lateral incisor is very important for the fitment of dentures, I mean obturator. So we'll cut the palate in the midline. Now this specimen is attached with only pterygoid plate posteriorly. This cut is very blind. We can't see where we are cutting. We take a curved chisel and just tap it. So our direction of tapping should be in horizontal or inferior plate rather than superior. Because above the pterygoid plate, I mean attachment of the pterygoid plate with the palatine bone, there is pterygomaxillary fissure and pterygopalatine fossa. There is maxillary artery. So if our direction is toward the superior direction, we can injure the maxillary artery, you can injure the maxillary artery, and there will be lot of bleeding. So this is about the total maxillectomy. Now if we have to do a infrastructure maxillectomy, anybody, what is infrastructure? How will you define how will you define infrastructure?
Nasal floor, and above the superior line of Sibelius, it is the suprastructure of maxilla, and between two imaginary line, it is the mesostructures, and below the inferior line of Sibelius, it is the infrastructure.
Okay. The classically, sit down. Classically, it was divided by a Orngrens line. Okay. That is extending from the medial canthus of eye to the angle of mandible. The structures posterior superior to that are suprastructure, and anterior-inferior to that are infrastructure. As you clearly see, the tumors above this line have a bad prognosis, and below this line they can be removed easily, so they have a good prognosis. So during the infrastructure maxillectomy, we have to remove the structure below the infraorbital, arbitrarily below the infraorbital foramen. So we'll give a cut over the anterior wall, which will be extended in the posterior lateral wall. Another cut, like the same cut which we have given in the total maxillectomy, it will start from the between the canine and incisor, lateral incisor, and it will reach the midline like this. Then extend posteriorly. On reaching the palate and the posterior portion, it will be directed laterally. Again, this specimen will attach to the pterygoid process, and that will be tapped. And this whole portion will come down with the teeth. Okay. So indication of this type of maxillectomy are usually tumors of the hard palate or minor salivary gland tumors or dental, the tumors of dental origin, which are not extending very high in the maxillary antrum. Now coming to medial maxillectomy, now we have to remove this portion of the maxilla, the medial wall of the maxilla or lateral wall of the nose. We have to remove this. So medial wall of the maxilla in the lower portion turn to the medial side and form the floor of the nose. So we have to give a cut along the floor of the nose, another cut in the, for detaching it from the nasal bone, we'll give a cut on the superior portion, and that cut will be extended in the orbit below the frontoethmoid suture line. Now this specimen is attached to the maxilla with anterior surface and in the floor of orbit. So we'll give these cuts along the anterior surface of the maxilla, and it will be medial to infraorbital foramen. In these cases, we would like to preserve infraorbital artery and nerve. And these cuts are joined, and this specimen is removed in a block. Okay. So this is about the medial maxillectomy. Now coming to reconstruction. After doing maxillectomy, this is a very debilitating surgery. It creates a lot of deformity. So what is the need of reconstruction? Why do we want to reconstruct the defect?
Question.
Anybody?
Question chair on the time. Right. Inauguration.
You are banned for just speak.
Okay. So that is an important part, and other than that, osmosis is one of the reasons.
Yeah. So we want to preserve normal swallowing and speech function. Okay. So we have to separate nasal cavity from the nose. So that is the need of reconstruction. Furthermore, with the latest free flaps, we have the option to go for a osteo-integrated implants. So patient can have a chewing function also. So what are the options of reconstruction? First, in medial maxillectomy there is no need of reconstruction. But coming to larger defect, we have lot of options. The easier and most prevalent one is prosthesis or obturator. It has to be made pre-operatively, and it will be fitted at the end of surgery to hold the pack. Second, we can go for a skin graft lining the defect with the obturator, and then these are the free flaps, temporis muscle free flap, anterolateral thigh flap, and forearm flap. These flaps can be used for reconstruction. The advantage of these osteomycutaneous flaps are that we can fit osteo-integrated implants. Now complication, I am not getting the detail, but as we can, there is in maxillectomy there can be lot of bleeding due to injury to the internal maxillary artery. We can injure optic nerve and eyeball. There can be CSF leak, and these are all intraoperative complications. The post-operative complication, we can have a cosmetic deformity, we will have a speech and swallowing problem, enophthalmos, as we are removing the vital fluid in total maxillectomy. Patient may have enophthalmos. If there is injury of some muscles or eyeball muscles, then there can be diplopia. Epiphora may be due to we are putting an incision in the subciliary region. If that is not closed properly, there can be ectropion that can lead to epiphora. Plus, we are cutting the nasolacrimal duct. That can also lead to epiphora. Then, sometimes we are injuring the infraorbital nerve and vessels, or sometimes it is cut deliberately in total maxillectomy. So there can be numbness or pain over the face. Now, all those things যেটা আমরা এখন করলাম, it will start with this first thing, okay, the specimen. This can start with the specimen. So that is the specimen. You can have, after the session you can have a look over it.
They can have a look. একবার ছবি দেখিয়ে দিচ্ছি, just এখানে এসো. হ্যাঁ. So just show them. And
first is identification of the specimen. How will you identify? দাঁত আছে মানে দুটোই জিনিস হতে পারে, either mandible হতে পারে নাহলে maxilla হতে পারে. And if there is turbinate, so it has to be maxilla. Now we have identified the teeth and turbinate. But anteroposterior.
So I think with that we have come to the end. Just you can see the picture. This will be discussed in your. Okay. We just discuss. We'll just show the specimen. So you have. আসবে. So আসছে না তো. Also talk irrelevant. So you have to create a relevance of the history. Irshado, jao. You have to create a relevance of the history, present it nicely. You should measure your words, what you speak, so that the examiner can lead to the right direction.
This is the zygomatic process যেখানে কাট করা হয়েছে, but there is no frontal process যেখানে কাট করা হয়েছে, frontorizal process. ওই প্রসেসটা এখানে properly visible নয়, but this is the process
You
where
want to
it was cut from
comment
the
at the end?
zygomatic bone. So this is the molar, so this is anterior, this is posterior, this is the zygomatic lateral one, and we can go for, if you can have a medial view, we can see the turbinates also.
कुछ points add कर दीजिए.
I don't know whether you are able to appreciate or not. These are the turbinates, okay? And this is a part of soft palate. So this is how we have to orient, and always if there is any specimen, you have to mention the side, which side it is. We just can't say this is a specimen of maxillectomy. We have to say this is a specimen of, this is a operated specimen of, right-sided maxillectomy, showing all those things. And after that, you can go for the diagnosis. There may be some syngetic mass which is coming out of the palate or coming out of the nasal cavity. You can describe that. One thing, if it is coming out of the coming out inside the nasal cavity, then it's better to say sinonasal carcinoma rather than maxillary carcinoma. Okay, that is what we should go.
Specimen में कुछ नहीं ऐसे will continue. अभी वो लोग inauguration के लिए 2 मिनट wait कर रहे हैं. So we will fire a few questions. We will fire a few questions to you, and we have our AY observer. So we have already talked about CT scan, we have talked about specimen, and you must also remember that whenever the questions are asked during your long case, during your short case, during your viva, either direction of the patient, it can go in the direction of the clinical side, it can go in the direction of the surgical viva, it can also go in the direction of the instrument, because always instrument viva you do not have to wait. So you have to understand that the moment you get a case, you sit down thoroughly with a composed mind, follow the standard protocol which are given in the textbooks, in the various books about writing the history, and then all our faculties have told you that important is to make note of the chief complaints properly and the chronology, because this is where most of the students get confused, and you don't even go to operative site, you don't even go to CT scan, and maybe you know so much, but you do not go to get a chance to go that much, because the long case finishes in the history and clinical examination. So you should be very judiciously placing yourself in front of the examiner, so that the examination takes place. I always tell my students that you should try to direct the examiner in what direction the examination is going, and do not direct to nanotechnology, do not direct to too much of navigation. That's not necessary. You direct to the basic things, and whenever you are given to read a specimen or a CT scan, you must describe it properly, like we have discussed in all the forms. We have to describe it properly in an orderly manner. Again, we have said that CT scan should be I think Dr. Verma just told you, the specimen, you must say that this is a specimen of whatever. As soon as you say that, examiner will ask what are the identifying features of, if it's a laryngectomy specimen also, they will, I think it will be discussed today, they will immediately ask you where is the disease, how do you identify, what are the structures. So whenever you talk about specimen, so this is how it goes. And with that, I think we will conclude this session. I thank all the faculties of this session for beautifully demonstrating all the things that were supposed to be, and all the best to all the examinees. Thank you.